Thank you, Dr. Chandrasekhar, for this wonderful opportunity you gave me. Generally, I'm not really scared of taking talks, but this was I was a little skeptical because it's not something what I do generally. But it's quite challenging to take this up, and I'm glad that I'm here today. So, with that wonderful introduction, what we just had, I think I'll just move on to what are the autoantibodies, what we generally do in diagnosis and follow-up of patients with systemic autoimmune rheumatic diseases. So that's going to be my outline. I'll just start with some introduction, go on to the autoantibodies in rheumatoid arthritis. We'll just have a broad overview of what anti-nuclear, used to be anti-nuclear, now they're called anticellular antibodies. A bit of autoantibodies in systemic sclerosis. ANCA, Dr. Chandrasekhar did mention some notes about ANCA. Autoantibodies in inflammatory myositis, which I think currently is the most talked about field. And then we just conclude with some takeaways from this talk. No disclosures for this particular talk. So when we talk about autoantibodies in systemic and rheumatic diseases, they're kind of diverse, and they like Dr. Chandrasekhar did mention, they are specific, they're basically against specific components of the cell. And what we know is it could be pathological autoantibodies, it can be non-pathological, but pathological, they form following a break in the tolerance of immune tolerance. And these antibodies have been known to have role in pathogenesis, early diagnosis, prognostication, treatment guidance, and monitoring of disease activity. And they can be present in healthy population as well. So one thing I always tell everyone for that matter is like, they generally say that autoantibodies are bread and butter for a rheumatologist because we are lab-based specialty, keep ordering. So I always tell them, I take the butter part of it, bread is always clinical examination. So unless you clinically examine the patient, have a good idea of what the patient has, so that starts from the history, goes on to examination, that's a bread, and butter is just what goes along with it. So unless you have a bread, which is a proper history, a proper groundwork of what the patient has, how long the patient has these symptoms, you really can't put butter on that. So with that, I think it's very important to understand what we need to order, because like what I said, what strikes me is like, many of them have these autoantibodies, different varieties at different stages in different titers. So, and then interpretation, like what I said, should be based on history, physical examination. And the other thing I always mention, regardless of what test we order, forget about autoantibodies, regardless of whatever test we order, we need to have a pre-test probability of what that test is going to come as. And that differs in different settings. It may differ from a primary setup all the way to tertiary setup, quaternary setup. It may differ from clinic to clinic, but unless and until we know what the pre-test probability of the test, what you're going to order is, don't order. Or just get back, learn about it, and then order. Because once you get a positive test or a negative test, you won't know what to do after that. So that's where we have, Dr. Chandrasekhar did mention about 10K antibodies. We don't know half of them in terms of what we do on a regular basis, but based on the disease we treat, we do have a few antibodies we certainly look for. Now, let's start with rheumatoid arthritis being the most common. We have close to about 1% of population being affected by rheumatoid arthritis. So we know that rheumatoid arthritis, it's often mentioned, it's RA factor. I'm reminded of my mentor, Dr. Danda, who's no more, but he's taught valuable lessons. He used to always say there's nothing called RA factor, it's rheumatoid factor. So there was a time when we knew that, okay, there was some arthritis existed, and then now we know that it starts quite early. You need to have a genetic predisposition, and those susceptible individuals who are at risk, they move on to a pre-symptomatic RA, that's where the autoimmunity starts, and then you transition to a symptomatic rheumatoid arthritis. You start with an arthralgia, and then finally the patient develops rheumatoid arthritis. Not just overnight, the whole thing develops overnight, but we know that it's a process, and at each levels, in fact, with the advent of imaging, we know that we can, kind of follow them through each of these levels, and we can. So what is important here is there are two antibodies what we generally use. First is the rheumatoid factor, and the second one is anti-citrullinated protein antibodies. We also have anti-carbamylated protein antibodies which we use. Now, this is essentially a post-translational modification which is part of the pathogenesis of rheumatoid arthritis. We have these two antibodies, but generally by far what we use is rheumatoid factor, and that's kind of specific for the disease itself. Now, what we need to know is this IG, generally what we have is an IgM antibody which targets the Fc portion of the IgG of the body, and this is it also has other things like IgG and IgA. And why we generally don't, we generally stick on to IgM because it's the most sensitive one, but IgA, if you look at it, it's highly specific. But however, because of the less sensitivity, because always remember when we have to pick up a disease, the test has to be highly sensitive. That increases the pickup rate, so that's the reason why we use IgA, or we use the IgG isotypes. And both these IgG and IgA can have severe disease phenotypes if you really look at from the rheumatoid arthritis point of view. Now, is it only in rheumatoid arthritis? Not at all. It can be there in normals. It can be there in Sjogren's in close to about 85%, chronic hepatitis B, early undifferentiated arthritis, juvenile arthritis. Healthy controls, like what I said, a fifth of them can have rheumatoid arthritis. Doesn't make them rheumatoid arthritis patients by any means. Mixed cryoglobulinemia is the other thing where you get almost all of them do have rheumatoid factor at a high level. Systemic lupus erythematosus, and of course endocarditis is also known to have rheumatoid factor. Now, how do we test it? Now, generally in the labs we follow one of these. The gold standard what is mentioned is nephelometry. Now, what is nephelometry is basically you have a light source here which goes through a prism, and then the light gets scattered, and this is the scattered light, which you have a prism which a cell, and you have a transmitted light. If you measure this is turbidometry and this is nephelometry. So basically the scattered light is measured at 90 degrees. That's the nephelometry procedure. You can have ELISA, and latest agglutination is probably one of the oldest ones which are not specific for rheumatoid arthritis or rheumatoid factor. However, it's a very good point of care test, and that can be used at any, even in community level. If you can just go and use it, it has a good utility in community. It could be a semi-quantitative, that's the best you can get. You may not be able to get a number, but it certainly helps in quantifying the disease. Now, this is something which changed the diagnosis of rheumatoid arthritis. We started with the first generation many years ago. Currently, we are in the second generation ACPA antibody, ACPAs, and we also have a third one, which is not supposed to be, it's not all that specific, nothing great than the second generation. However, essentially what we need to understand is because of the post-translational modification, which has a role in the pathogenesis, like what I mentioned, and then you have a transformation of the arginine residue into citrulline, which is called the citrullination. You can also have a peptidyl arginine deaminase. This is the enzyme which triggers the whole thing, and this is essentially detected by ELISA method. So like what I mentioned, you have the first generation, which has synthetic peptides from human filaggrin. The second generation, they started, the initial one was a linear one. The second one, they used cyclic peptides. And the third from vimentin and filaggrin. And the third one we do have, but I really wonder if it's going to have much of a benefit as compared to the second generation in regular use. Moving on to ANA, this is another test which is used far and wide. We have values for ANA like 1.6, 1.2, all the way to patterns with the specificity, intensity. So always remember, ANA has to be done using something called indirect immunofluorescence testing. The sensitivity for ELISA is great, but at the end of the day, what we need to know is each antibody or each ANA pattern denotes one particular set of antibodies. And unless we have the pattern, it's very difficult to understand. Patients come with reports saying ANA is high or ANA is medium, low. Doesn't really make sense, because for me it has to make sense looking at the pattern and how intense the pattern is. So if you look at it, these are already, it was called ANA because it was directed against the nucleus, but now we know that it's called an anticellular antibody or anti-cell antibody because we have the other parts of the cell, which includes the cytoplasm. It can be nuclear, and we have a whole host of patterns and ANA patterns which we can get from each of these things. I wouldn't really go into the details except for a few of them. So the homogeneous one is the most, I would say, is the most common one. It basically there's a diffuse staining of the nucleus, and it targets the histone proteins, and is basically seen in double-stranded DNA and single-stranded DNA. One of the most important diseases what we test ANA for is lupus, and that's why we get lupus over here. It can be there in drug-induced because of the histone proteins. Sjogren's, scleroderma, rheumatoid arthritis, we generally don't check there, but we do get in PBC and or primary biliary cirrhosis and autoimmune hepatitis as well. Now, the nuclear pattern is, again, the next one where we have a fine speckled and a coarse speckled one. The fine speckled generally. So what we need to remember is when you see a pattern, it generally denotes a particular antibody. So you basically have a hunch of what exactly the antibody is going to be, and then you can go and do the ELISA titer for that particular antibody to get the titer and see how these antibodies perform. So we have a fine speckled. So here's the mitotic cell, which acts as a negative control, and then that's a fine speckled in the nucleus. Generally seen in topaz, which is SEL70, or it could be Rho60, which is Rho and La, which could be there. And nucleus speckled is the next pattern where you have, like, again, coarse speckled, fine speckled, and we also have a dense fine speckled for these things. Just the essence is essentially back to the basics. We have to have an intensity. It has to be generally what we say is 2+ above would be something which is important, and we need to have a dilution level as well for these things to be really important. Nuclear is the next one where we have a series of antibodies out there. Like what I mentioned, it's in PMSEL, U3RNP, RNA polymerase 1, 2, and 3 is generally nuclear, and we have the disease association there. Nuclear dots. So there are a lot of these patterns which have come up, and it seems to be keeping on increasing by the day or by the year when they have a new international it's called the ICAP, which comes up with all these definitions and new patterns every now and then. And this is what we have today in terms of the ACA pattern involving the cytoplasm. So earlier it used to be like what I said, it was the ANA. So now we also have antibodies in the cytoplasm which have been discovered, and now you broaden the thing beyond the nucleus, and it's called the ACA. And that's how we have the anti-mitochondrial antibodies, cytoplasmic fine speckled, cytoplasmic staining over here, with all these new antibodies. I wouldn't say new, but fairly new as compared to like the old dsDNA, for instance. And what has driven this thing in this field, most of it is the disease myositis, inflammatory myositis, where we learn each day, and how we define the disease itself has changed because of these antibodies. So coming to anti-dsDNA, so this is kind of the test what we generally use for lupus patients, and this is one of the tests which can be used for diagnosis, not so much for the diagnosis, but I would say for follow-up of the patient is very important, because this is something which we look forward to becoming negative by whichever method we test following treatment. So this is one of the very few antibodies which we generally keep on testing, because lupus is something which is quite active always, and the moment you treat it, we need to see how much we have treated and what target we need to get by the treatment also. And it has, like what I said, it has a good association with disease activity and lupus nephritis. Like I said, it's used in the monitoring of the disease. And like I mentioned with the ANA pattern, it's generally a homogeneous pattern. And generally what we use is ELISA can also use IF by Criteria lucilia, which is a very specific one, but we generally use ELISA for most of the labs. Now, coming to each disease specific, we have scleroderma, where we have 3 sets of antibodies, what I'd like to focus. The first one is the topoisomerase, which is for diffuse kind of systemic sclerosis or diffuse systemic sclerosis. Then we have the centromere, which is for the localized scleroderma, which is the CREST syndrome. We can also have topoisomerase 3, which generally has association with renal crisis. So that's something which has its importance in terms of complications of the disease as well, beyond its diagnosis. Sjogren's is another variant which is known as the Sjogren's disease now. Earlier it used to be Sjogren's syndrome. We know that it goes beyond the joints. It is a multi-system disease, so it's called Sjogren's disease, and we all know it's the Rho and La, or the SSA and SSB antibodies, which are specific for Sjogren's disease. And generally what we say is, if you have a SSA antibody, because in India I think we need to be very careful when we order tests. First of all, like what I mentioned, you need to have a pretest probability. And the second thing we need to be really worried about is the pulse of the patient, because you order a whole host of tests and the patient exhausts everything. Obviously, he or she may not be very happy, and it's not that everybody has so much to pull out to the labs in India. So we need to be a little mindful when we order tests. So generally, SSA, if it's positive, we get the answer, and it's very, very, very less than 5% of patients who are SSA negative but SSB positive. So essentially, if you just need to order for a diagnosis, I would just go for an SSA. So that's something we need to be mindful of. Now, anti-neutrophilic cytoplasmic antibodies, which are called the ANCAs, it's essentially, we have 2 methods by which we generally test. It used to be 2. But now from 2017, they made a different, they took off the IF, which used to be the screening test, and then we, depending on the pattern, we used to do a ELISA. So now, from the 2017 change in the testing rules, they've taken off, and they've just asked us straight to go for ELISA. So we have cytoplasmic one and a perinuclear one, which is C-ANCA and P-ANCA, denotes different types of diseases, and a minority of IF which do not fit in either of these patterns is called the atypical ANCA. And this is what I was talking about, the way we've understood ANCAs over the years, right from 1982, where ANCAs were first associated with glomerulonephritis. C-ANCA was in 1985, all the way to 2017, where they had a revision of the consensus for ANCA testing, where they took off the IF as a screening test, and we can straight away go for, depending on the disease, again, we don't really test for ANCA both, but generally depending on the disease. And here's another one which we generally monitor if the patient is in remission or not, because that's, other than the dsDNA, this is one of the tests which we check if the treatment is on right course or not. This is the other way. This is the picture what I was talking about. So initially it was the IF, which is the indirect immunofluorescence. We had to do that, and then based on that, depending on the pattern, we used to do ELISA. But now the recommended approach is straight away, depending on the disease, what we suspect, we can straight away go for ELISA, and if it's ANCA negative, we have a second assay, and ANCA positive, we have a second assay there. So this is what we have today. C-ANCA we have mostly for GPA, which is granulomatosis with polyangiitis, which used to be called Wegener's, and also with microscopic polyangiitis, whereby in P-ANCA it's mostly for microscopic polyangiitis, and EGPA, which is earlier called the Sturge syndrome. We also have a whole host of diseases which can have P-ANCA, because this is probably not as specific as C-ANCA, but C-ANCA, you can have a P-ANCA, you can have a whole lot of diseases which it can have a positive test, and we need to be aware of that, because C-ANCA is certainly more specific than P-ANCA as such for the particular diseases. Now, antibodies in idiopathic inflammatory myopathies, this is one area which has really changed our understanding of the disease itself over the past few years. And it's still changing, because I'm sure we haven't really reached there as yet, because every day we learn something new about the disease, and this is a kind of a nascent field which a lot of people are working in. It used to be known as dermatomyositis, polymyositis. Then there was one, the third type, which was generally a pediatric type. And then we used to have IBM. So these are broad classifications earlier, and now that's all broken off with the antibodies we have. So we know today that it's based on the antibodies. How do we kind of phenotype the disease in terms of its symptoms, in terms of its complications, in terms of its long-term diseases, and in terms of the association that has with other organs. So that's very important, especially cancer-associated dermatomyositis is something which we've learned over the years. So this is something which we've learned a lot over the past few years, and we're still learning what I mentioned. So the dermatomyositis subtypes, today we know that it's anti-Me2. It's based on antibodies than earlier what we used to talk about, dermatomyositis, polymyositis, and IBM, what used to be earlier. And then, of course, they had the statin-associated myositis. So those are like a bit unclear kind of a definition, but now these days we know that each antibody has a particular type of phenotype, and that is why we go by the antibody, each of these. So we have Me2, we have MDA5, TIF1 gamma, and NXP2, and each of these have specific clinical features. And of course, today we have IBM, which is basically seen in men over 45 years of age. Now, this is one area which a lot of work is being going on, which is the immune-mediated necrotizing myopathy, which essentially is connected to the antibodies SRP and HMG-CR autoantibodies. And generally speaking, these are mutually exclusive. So you can't really have two antibodies at the same intensity. So one of the tests, what we do here is line immunoassay, where you have a blot, and depending on the blot, we look at the severity of the antibody. So we generally go with the highest specific one, and all the others will be a bit of a noise there. So that's one thing what we need to remember. Generally speaking, the antibody which drives the disease will have the maximum intensity. So maybe a 3+ will be something which we'll be really hopeful for that particular antibody. However, we'll have 1+, 2+, which can be kind of ignored, because generally we know that these are mutually exclusive. And like what I mentioned, it can be detected by ELISA. Line immunoassay is the most, and the dot blot assay. These line immunoassay is the most sought after test for inflammatory myositis. This is the understanding graph what we have as of today. We started Me2 in 1976. Jo1, which is anti-synthetase, came up way back in 1980s. So essentially, then it kept on increasing over the years, and today in 2023 we have and it just keeps adding every year. So that's something which, like what I said, what we've known over the years, and today we can kind of characterize the disease itself based on the antibodies. So we know that muscle necrosis is essentially caused by SRP antibody, HMG-CR. Lung involvement is synthetase. Then you have skin involvement by mostly Me2 and SAE. MDA5, again, lung and skin. So this is how this disease is moving at the moment. And especially the cancer-associated one is the most important thing. And we do have recommendations on how to screen these patients depending on the antibody for cancer screening. So that's something which we learned over the years. Like what I said, these are the two antibodies, TIF1 gamma and anti-NXP2, which are the cancer-associated, and each system kind of has a definite antibody predilection for each of these phenotypes of the disease itself. Extramuscular, we have ILD, which is, again, a big part of rheumatic diseases, as we know each of these antibodies by the day. Cardiac involvement and ILD are the most important things. Pediatric considerations, I would just leave it for the next talk, because I'm sure the next speaker will be dealing with the pediatric, which seems to be a little different, at least in terms of the cancer-associated antibodies for pediatrics and in adults, as we know for today. This is what I was talking about. There's something called IPAF, which has been developed over the past few years. There's not a particular disease in itself. We still are in a gray area there, whereby patients do have an ANA positive, which has to be more than 1:320, like what I mentioned. And then you have a set of clinical features, which includes mechanical hands. It could be digital ulcerations. So essentially, these patients cannot be typed into a particular phenotype or a particular part of the disease, but they do have features of inflammatory myositis. It could be arthritis, a fair bit of lupus-like or MCTD-like features, and a good amount of serological features, and they have a NSIP or one of these patterns. So this is one area. Again, this is something lot we are understanding by the day. Now we can type this based on the HRCT and the antibody. So we have NSIP type, OP type, and the treatment varies for each of these things. For instance, for OP type, which is organizing pneumonia, we'd like to start with a good amount of steroid, which really helps, where in NSIP we can go a little slow with not that high dose of steroid. So a bit of everything put together. What we need to know is a lot of these antibodies have helped us in the understanding how the disease progresses, how the disease is diagnosed. So a lot more to come in the years, at least in this field, now that we're clubbing antibodies and CT findings, mostly HRCT findings in patients with IPAF. So just winding up, we have a few take-home messages. Antibodies are basically biomarkers for diagnosis, prognosis, and can be used for follow-up. But we should know where to use them for diagnosis, where to use them for prognosis, and which one to use for follow-up. I do have patients coming up saying that every 6 months they repeat the rheumatoid factor and say that the value is not really coming down. And each time they go to a different doctor, the same set of rheumatoid factor, ACPA will be repeated. Doesn't really make sense. So we should know what to order for diagnosis, what to order for prognosis, and what to order for follow-up. That's really important. Clinical pattern is the thing which should drive the testing of autoantibodies and not the other way around. We shouldn't do a ANA and say that, okay, fine, this is positive, so this must be the disease. It should be the other way around. We should know what the pattern is, and then you order the exact antibodies, and that will give you a fulfilling report. Other thing is know the sensitivity and specificity. Both these things are different, so we need to know how specific. Again, it depends on what you're going to do. If you're screening for a disease, I would recommend you to go for something which is more sensitive than specific, but it's the other one, it should be more specific than sensitive. So we should know the sensitivity, specificity, should know the pre-test probability of each of these tests. Think of pre-test probability always, regardless of what test you order. Even if it's a hemoglobin, you need to have a pre-test probability. If not, then you can be misled big time. Autoantibodies can be present in normal population, so always be beware of that. And you need to, again, fall back on your clinical skills, on your history-taking skills. Like we always say, if you're not getting a diagnosis by the end of history in a autoimmune patient, I think 75% of the times what we make up is from the history. And if you're not reached a history diagnosis at the end of your history taking, there's something amiss, so you need to go back again. So we need to always be putting the antibodies in perspective to the disease itself. And the last thing I'd like to point out is the standardization of labs. It's always good to follow a particular lab because you always know good or bad. That's a different thing, but at least if you know it's bad, it's consistently bad. If it's good, it's consistently good. So it's always good to have a standardized laboratories are warranted, especially when patients come for follow-up and ask which lab should I follow the test for. I think with this, I'd like to end and be happy to take any questions.